You can see some occluded vessels. You could see hemorrhages. You could see some sheathing here, some engorgement of some veins. This is typical vasculitis. But then, what is the cause is that always the challenge. So you can drop in some of your differentials here. What could be causes for, yes, Crohn's disease, very good. Arthritis, giant cell arthritis. What else? Behçets, good. Okay. What else? Yes, it could be CRVO. But when you have sheathing and so on, you should always think of the, yes, syphilis. Syphilis can cause anything. SLE, yes. Sarcoidosis is very good. Hill's disease, idiopathic. Toxo, GC, tubercular, very good. Who said tubercular? Dr. Jyoti Bastala Paudel. I just wanted someone to mention tuberculosis and you did it, so that's very good. So someone said Susak syndrome. Yeah, Shaksham said Susak. Very good. So at least from my experience, we should always think of tuberculosis in our setup. I mean, this could be different in India, this could be different in Nepal, but I believe that there's from the colleagues of mine who are working in uveitis, it is very common to find patients having vasculitis, and they turn out to have tuberculosis some way or another. So it's always important to screen them for those because that might change a little bit of the treatment, right? You might have to put them on anti-TB before you start them on steroids. Of course, there are also viral causes. You should not forget those. At least you need to rule out some of the infectious causes before you embark on saying like it's just autoimmune inflammatory disease. Else disease, some say it is related to TB. So that's why I put them in the same bracket. There's always a controversy with that, but you should think of that. But at the same time, masquerade ones like any tumors could have a similar manifestation. You should think of that already. Shaksam said Susak, which this one is associated with hearing loss and strokes, and this is very common in women, the third decade, and any chronic embolism, which could be because of cardiac valvular disease, cardiac arrhythmias, and so on. Because I remember I've seen one patient when I was in Juma in Southwest Ethiopia, where we diagnosed CRVO. Uh, she was not symptomatic of any cardiac disease, but then when echo was done, she had mitral stenosis, mitral regurgitation, and tricuspid regurgitation. And I don't know how she didn't have failure till then, but she was near to have some carpulmonary disorder. So all these things can be diagnosed from our side sometimes, which things may not be noticed by other colleagues. So it's important to always um, try to screen some of these issues. Of course, when you have exhausted with all the secondary causes, you could think of idiopathic causes like some reports on this IRVAN is there, so it could be a collection of retinal vasculitis, aneurysms, and neuroretinitis. Our case was PPD positive, tuberculin test was positive with greater than 50 millimeter in duration, and other workups for vasculitis were negative. Anti-TB was initiated, and then he was put on systemic steroids, and OCT actually showed macular edema, so peripheral laser was applied after some anti-VG, and then he had PPV and phaco for the left eye, but it had very much necrotic retina. The peripheral retina was very necrotic. I did some retinectomy, but the visual outcome I knew was very poor. Um, but the right eye was is doing well with the peripheral lasers applied, and the macular edema has subsided, and he has 6/9 vision at this point, and the neovascularizations are subsiding. So the other case is a patient who came uh, requesting cataract surgery on the right eye, and he's actually a very well-known, traditional healer in our country, and he came with such a complaint that he had cataract surgery on the right eye. He wanted to have the cataract surgery on the right eye, but he already had cataract surgery on the other eye, and 5 months back, and he was not happy with the visual outcome, so he wanted me to do it. But then, you know, everything was clear in the anterior chamber. Everything was well done from my point of view, and there was no sign of complication on the cataract surgery that was done, and refraction didn't reveal much, and he was not improving with the glasses. But then I saw there's a little bit of foveal uh, loss of foveal reflex. So easy to diagnose, right? What should you think of in such cases? Yes, Irving gas, very good. So what are the clues? Typical clues. Typical clues. The timing. Everything is well. I mean, of course, you will have more incidents when you have complicated surgeries, but it doesn't mean that with kind of what looks like a perfect surgery could actually have poor visual outcome because of Irving gas. So these are typical findings, like you have this petaloid pattern because of the arrangement of the fibers, right? And then you have this cystoid type of macular edema, which uh, which is typical of cystoid macular edema. What are etiologies of this? Yes, you have already said Irving gas, but then you could still have CRVO, BRVO, uveitis, retinitis pigmentosa, all these things, and hypotonia of any cause could result in this. So can you post some on the chat? What drugs can cause CME? Yes, prostaglandin analogs, tetracycline. Yeah, there are a number of medications which can cause that. Uh, this taxanes like paclitaxel, docetaxel, these are chemotherapeutic agents, like these are antimitotic ones. So this can lead to that. And nicotinic acid, if you are giving it for vitamin C deficiency and so on, that might lead to CME. But what you should always think of is if it is not linked with leakage, you should think about that. And at the same time, other disorders like retinitis pigmentosa, retinoschisis, Goldman-Fabry, these ones could be linked to CME, especially if you don't have leakage on FA. So how do you treat it? Yeah, so this is topical corticosteroids and steroid inflammatory drugs. You could think of the periocular steroids, but then especially if there's no leakage, you could always add, topical or systemic acetazolamide. Even with the ones which are leaking, you could think of that. And if there are vitreous strands, uh, for example, in the anterior chamber, you could do YAG laser to relieve those strands. But if you have to do, if the edema is related to VMT and ERMs, of course, you may have to do vitrectomy and ear limb peeling. So another case. So a 6-year-old boy was brought to the OPD with loss of vision and pain on the right eye. So he has hyphema, neovascularization, severely engorged, dilated vessels, exudations, detachment, anything that comes to your mind. A 6-year-old boy, ghost disease. Yes, very good. So unilateral in a 6 to 8-year-old boy, with all these findings, you should think of coast disease. You know what's coast disease? It's non-hereditary, very rare. It's a gene. It can be somatic. It's the somatic gene, this NDP, norrin disease protein gene on chromosome XP11.2. It can cause this deficiency in norrin protein products. It has high male predominance. That's why 6-year-old boy is a very good clue. And typically you could have on the pathology, you could see on the arrows, there's accumulation of uh, histiocytes and also exudates in the subretinal space, which contain, it can contain like lipid, cholesterol crystals, and so on. So this is the pathology that you'd find on the histology. And there is, of course, high expression of vascular endothelial growth factor. And the boy that I saw in Jimma actually ended up having, he was later blind because of, too much neovascularization. There was neovascularization glaucoma. He lost most of his optic nerve, and at the same time, he had pain, and cycloablation was done. Uh, so this should be something to think of. So Ashiana has given you some mnemonic to remember causes of CME, deprivant that you
So
could think
it's
of.
the opposite, right? When you're swollen, but when you're deprived, it's the
Yeah,
opposite, right? And so if you remember depriving, you'll remember the causes of CME.
perfect. Thank you. So this was typical of what I saw in my patient. So it's not my picture actually. It's from BCSC, but it is typical of what I saw. So, but then you have to always think of the other differential diagnosis, like familial exudative vitreoretinopathy, facioscapulohumeral muscular dystrophy, ROP, and von Hippel-Lindau disease. But then, we'll come back later on to differentiate them. Of course, the management is very difficult, but if you find it early, maybe you could think of the cyclophotocoagulation, cryotherapy, and PPB for retinal detachment, and adjunct, anti-VEGF therapy, and also glaucoma tube shunt surgeries. So, patients could come with leukocoria, with retinal detachment related to coast disease, but then there are other causes of leukocoria. So it's something to revise, how you can differentiate among them. Of course, one typical thing like that we should see is the age, So if it is congenital, you should think of cataracts, but it's 1 to 3, this 18-month old child, you have to think of retinoblastoma. Again, when it is congenital, PHPV is also one thing, but PHPV is usually unilateral. Coast disease is also unilateral, but is in older kids. And retinopathy of prematurity, of course, when there is prematurity. So age is very important in diagnosing what causes leukocoria. And again, to differentiate between familial exudative dysphagia and ROP, prematurity is one thing that you should consider, and family history will be present in the. I mean, may not be always present, but if it is present, you should think of favor, and favor is always progressive, but retinopathy prematurity has a chance of regression, and it has some chronological distinct changes. But favor is a little bit unpredictable. It can reactivate at a later age, even at adult stage. So certain forms of retinitis pigmentosa could simulate Coats disease. So that's something we should also think of. So this is case 5. So this is a 30-year-old man who came for routine eye checkup, and there was loss of foveal reflex and yellowish exudates on the right eye, and OS was fine. There is a little bit of visual disturbance, but no other remarkable findings. So any ideas what this is? So DME. Okay, so yes, it's solar retinopathy with, okay, good. TCR, Stargardt, okay, McTail, very good. BRVO. So all of these are logical uh, things to say. The only thing maybe CSCR. We'll come back later, hopefully on that, but it might not be typical of CSCR, but the others could still be some valid arguments. So actually, this is actually McTail. So the typical things you'd see are, around the exudates. I'm not sure if you can see them, but there is some uh, dilatation of some of the basals there, which is difficult to see here, of course. but just adjacent to that, you find that edema on the macula. Okay, so depending on the type, there is unilateral parafoveal telangiectasia, which is congenital or acquired, but there is type 2, which is bilateral. And there is type 3, which has also some occlusive components on the capillaries. The type 3 is very rare. So the typical one macular telangiectasia is the type 2 one. But the type 1, some say it is a variant of coast disease. We already discussed about coast disease. So typically you'll have CME type of things and yellowish exudates, and anti-VEGF therapy could help. But then the MACTAIL 2 is the most common one, and it is progressive, bilateral, and it is typically a neurodegenerative disease. So it begins with the fifth, and it's usually between fifth and seventh decades. And there is retinal foveal reflex will be reduced, of course, and there is retinal graying, and there could be deposits, ectatic capillaries, and so there could be subretinal neovascularization, and it is typically Muller cells are at the center of this pathogenesis, and typical findings, this type of cavitations, which are horizontal type of cavitations. When you see such type of cavitations, you need to think about it. This type of cavitations could be seen on OCTA, and this telangiectasia, this one, for example, it's very typical of this horizontal, long, cavitations in the OCT. You could see them.
So just recently, I was diagnosed with MACTEL type 2.
Oh, okay.
And it was so interesting because they had done a retinal OCT and they found that the inner layers had exactly that, like exactly where your point is. That's exactly what they found. And then even the outer layers, how it's like, it looks destroyed, like in your bottom photo, how the outer layers also look destroyed. And
this one.
Took three retinal surgeons and a neuro-ophthalmologist from different institutions to diagnose it. So I thought it was so interesting because I'm, first of all, not in the age of 50 to 70, and I wasn't having symptoms, but when they found it, they didn't, and it was the first time I had an OCT, so they couldn't figure it out. They did a visual field, right? Because we know that visual field gets affected centrally with macula versus glaucoma is peripherally. So they did a 10-2 of the visual field and a 24-2, and mines were completely normal. So then they did OCT angiography, and they saw, the blushing of the vessel, of the telangiectatic vessel, and that's how they confirmed that I have MACTEL type 2, and it's bilateral for me.
Yeah, and it's only even for me, I was it noticing when I went to Michigan, where I found lots of patients with MACTEL who were following with one of my mentors there. So that's when I really knew that it is something. Otherwise, it's something that you jump whenever you read, and you don't feel like it's very important, but it's very important, and something that can be missed, as you said.
And I have no symptoms. I'm 6/6 vision, right? Excellent vision. I have no problems. So how many of these patients get treated in your experience?
Yeah, I mean, how many would get diagnosed? That's one the question. So yeah, and most of them, I would say, are not going to be treated because they are not going to be diagnosed anyways. Because like you said, most of them may not be symptomatic at all, and they could be masked with other problems. If patients have diabetes and other things, of course, these things could overlap, and they might get treated for diabetic maculopathy or CME or something like that. So typically, unless there is a neovascularization or some kind of hemorrhage, which can lead to reduction of vision, in that case, of course, we treat it, whether it is mocktail or whatever it is. Typically, the treatment would be the same. So, what about this one? What is this? VHL. VHL. Everybody's saying VHL. Good. So, what is VHL? It is an autosomal dominant one. It has incomplete penetrance and variable expression. Hemangioblastoma, of course. Yeah. So, but it can be spread among every, every visceral organ that you could think of. But these are the most common ones. But it's important to know that it is a hereditary disease and it has systemic manifestation. So management is cryoablation or laser ablation. You could do PDT, and but it's very typical to see. So, but the most important thing is once you see it, then of course you have to screen for other problems. What about this one? Weber Mason, very good, Santi Karnam. Spot diagnosis, right? It's very typical. I have to be honest, I've never seen one. This is also something to think about. And typically, there is no leakage on the FA, and similar, malformations could be there in the mandible, and this is very important in dental extractions. They might be surprised somehow if when they find it. Now, what about this one? What is this? These grape-like things. I've given you a clue. Astrocytoma, which is a very good differential, very good differential. But look at the distribution. It's along the basals. Retinal cavernous hemangioma. That's very good. So retinal vascular hemangioma is typical of these grape-like lesions. Typically, you could see that it is limited in the basals, and you don't see a lot of leakage. Another clue is, you might find cavernous hemangioma in the brain too. You could see there's one here. So I don't want to go into detail about it. What about this one? Radiation-associated maculopathy. What else could it be? Why should it think like that? So it could be anything. It could be diabetic retinopathy. It could be because you have exudates, and so it's not only typical. It's only when you find this, you should always ask if there is the important thing is asking for history of radiation, especially patients who have had treatment of radiation. When you find this one, you always need to think about the cause of it could be that, right? But yes, a retinal artery microaneurysm could be one cause of this. DME could be one cause of this, of course. So you need to be open about it. But history is very important in such cases. And typically, patients who had brachytherapy or radiation therapy should be taught about it. So the treatment, anti-VEGF, and make sure you are not lasering these patients because it leads to atrophy, which is why it is very important to differentiate it from diabetic retinopathy, diabetic macular edema, for example, where you may have to do laser. This case, 20-year-old man came with blurring of vision, and this is actually although the photo is not mine, this is a recent case that I have had. So he had with a similar presentation. He's a 20-year-old man. He was mugged. He was not hit on the head or on the eye, but he was choked for a while, and then he came with this. So what could this be? Valsalva. Thank you. Very straightforward. Differential diagnosis for this type of things, you should think. Okay, of course, the patient might not say I was not hit, but then you have to screen for retinal breaks if there is PVD and maybe it's also nice to check for retinal macroaneurysm with OCTA, and OCT also could help you a little bit. So I'm going fast because these ones are very straightforward. So what is this? 35-year-old comes with poor vision. So he had hemopneumothorax and refracture. He sustained during a car accident, and he had this one. So what could it be? Yes, pushers. So this could be caused by, typically it is caused could be caused by anything which might be related to compression of the chest, or head injuries, bone fractures, and so on. But what I want to focus on is some um, some problems like pancreatitis, for example. Acute pancreatitis could cause pressure like retinopathy. So similar to that. So the whole point is the injury is not caused by direct, trauma, but it is related to complement activation, granulocyte aggregation, leukoembolization, and occlusion of the vessels. So what about this one? Exactly. So this one is again Terson syndrome. Very good. So it is related to this one has subarachnoid hemorrhage, and there is hemorrhage on the subhyaloid space. There is also some edema on the disc. The pathophysiology is related to the acute rise in the intracranial hemorrhage, and it causes rise in the intraocular venous pressure, and this relates to peripapillary and retinal vessels will be ruptured, and this is why there is this one. So another very important point is retinopathy of prematurity. So this one is very it's also a public health problem of middle income countries. Even low income countries are going towards middle income countries, growing towards that. So they will be faced with this problem because there is more survival of premature babies all the time. So when the more they survive, the more likely that we might see this. So we need to be aware of this. This is very important. So basically, we say premature if it is less than 37, but ROP is more common if it is less than 32. And so based on the pioneer study like this cryotherapy for retinopathy of prematurity, that's where we derive some of the risk factors. So especially when they have low birth weight, there's higher chance of ROP. So typically, vascularization, starts at 16 weeks of age, gestation, and then it progresses towards term, and nasally it's reached at 36 weeks and temporally at 40 weeks. But if that is halted before that, then there will be relative hypoxia, which is in the first phase, hyperoxia, I mean, because typically in the uterine phase you'll always have low oxygen. So suddenly when the neonate is born, then there will be relative hyperoxia, and that would lead to lower demand for retinal oxygenation, and this arrests the production of vascular endothelial growth factors and insulin-like growth factors, and this will halt the retinal blood vessel growth. But then when the vessel stops growing, then there will be more oxygen. I mean, the oxygen will be insufficient. There will be more metabolic demands. Then that would be relative hypoxia, and then again there will be a rise in VEGF that leads to neovascularization and then all the complications. So you need to be aware of the international classification of ROP. So I would not go into the detail of that for the sake of time, but what is very important is to know the threshold ROP. So what is threshold ROP? It is uh, it is actually the boundary between having a spontaneous regression and progression to unfavorable outcome. So this one is defined as, at least when you have 5 contiguous clock hours of neovascularization, and or if you have 8 non-contagious ones with plus disease in zone 1 and or zone 2, then you say it is threshold. Later, there is a threshold for early treatment, and they have divided into type 1 and type 2. So these are the classifications you need to be aware of. I'll leave you to read on the grading, but maybe you could put in some of your observations. So what grade is this one? Stage 0. Why stage 0? Because you don't have any differentiation between the vascularized and the non-vascularized, right? There's a smooth transition. So there's a chance that this one will grow very well. What about this one? Stage 1, because you have demarcation, right? You have a little bit of demarcation, whitish demarcation here. and then you have a ridge, and then you have this one, which is a 3D, right? You have elevation, phase 3. So again, now you have even more because you have, what is this one? When you have such engorgement, what do you call that? What is this? Engorgement, dilatation, plus. Yes, very good. So I'm sure you know what zone 1, zone 2, and zone 3 is. And based on that, you can document things. And when you could have partial detachment, which is this one. I mean, you could have a detachment, but it may not be closed funnel, but this one is closed funnel. Everything is closed. So this is the last stage. So what do you call this one? APROP. Yes, it's very. This one is very aggressive. So this one needs very urgent anti-VGF because there is engorgement. It is in zone 1. It's very difficult to salvage unless you do it very urgently. Please be aware of all the common terms that are used. So type 1 is zone 1, any stage of ROP with plus disease, and zone 1, stage 3 ROP without, if it is with plus disease, zone 1 at any stage. But then if there is no plus disease, it has to be stage 3, zone 1, or zone 2 with stage 2 or stage 3. So typically we treat this one, okay? But the type 2 ones are, you can follow them. So the screening criteria, again, low birth weight, less than 1,500, and the gestational age should be less than 30 weeks. And I mean, if it is less than 30 weeks, you have to screen them. The first examination can be done at a postnatal age of 4 to 6 weeks or between 31 and 33. But then there is newer algorithms, which we call WinROP. Uh, so that can also help a little bit more. So there is a schedule for it. So I also don't want to go deep on it, but I just want to emphasize that it's very important for you to remember these schedules, and also when to screen. Okay, so when to screen and when to stop the treatment. So the management typically is for type 1. For type 1, all these types of ROP, you need to do laser. Their laser is better than cryo at this moment because of some of the to avoid more complications. And typically you should do like 0.5 to 1 gram, which is almost nearly confluent type of laser around 360 in the ora serrata and up to the ora serrata. And you need to treat all the avascular retina, and you expect reduction in plus disease in 1 week, but the most regression would happen at least within a month. So again, newer trials have shown that even bevacizumab can be given. There is what you need to be sure is there is a recurrence. There is a reactivation. So you need to follow these patients. Just because you gave them anti-VEGF doesn't mean that they are cured. So you need to follow them very well. There is also the Rainbow study, which compared which is for ranibizumab, so which has also similar benefit, but again there is the recurrence, so we need to be careful about it. One thing that is very important is when you inject anti-VEGF for neonates, you need to have you need to be at 1.5 millimeter, and you can give half of the dose of the as you give for adults, and as opposed to going for the obliquely towards the center of the globe, it's important to be parallel to the visual axis so that you don't damage the lens. So as a summary for ROP management, the most important thing is we treat the type 1 ones, and anti-VEGF may be preferred for those which are of posterior ones, like zone 1 with plus is in the APROP. This one, maybe the only chance we have is the anti-VEGF, but maybe upon discharge, it's always nice to think of laser therapy. Of course, in the later stages, stage 4A, lens sparing PPB or scleral buckle can be done. So we need to be aware of all the sequelae that could be uh, because of the ROP. So even as simple as amblyopia could be the cause of blindness. So we need to follow the patients very well.
And I'm Santi, Karnam, one of the global ophthalmology fellows at Philadelphia. So Dr. Nariani graciously asked me to help teach a couple of these chapters. So moving ahead, I'll be doing chapters 10 to 12 in the spirit of making things as interactive as possible. In terms of the objectives of this talk, there's 3 chapters. Chapter 10 is about myopia and pathologic myopia. From that chapter, I think the most important thing is just to understand all the various posterior segment manifestations of pathologic myopia. So we can do a little exercise there. Chapter 11 is about focal and diffuse retinal and choroidal inflammation. So for that chapter, it's a pretty hefty one. It includes basically every source of retinal and choroidal inflammation. So whether it's infectious, non-infectious, autoimmune. So I decided to focus a little bit more on the white dot syndromes, because that tends to be the more heavily tested kind of topic. Of course, you'll get asked questions about ARN, and you may see, patients with ARN or CMV retinitis, etc. It doesn't mean they're any less important to learn, but usually the thing that people have a lot of difficulty with is, remembering all the different white dots. And then finally in chapter 12, that one talks more about hereditary retinal and choroidal diseases. And that also is a pretty hefty list of diseases, anywhere from retinitis pigmentosa and all the RP-like syndromes, as well as the pattern dystrophies and congenital forms of night blindness, and as well as color vision deficiencies. So I focused on, once again, the things that are usually have more like characteristic features, and just how to learn to differentiate between one and the other. And just in terms of initial management, what's the first thing you need to do? What's the first test you need to think of? How to keep a differential diagnosis in your head, etc. All right, so starting off at chapter 10, a 55-year-old man comes in with an axial length of 27 millimeters, a refraction of -6. He presents to your clinic with the following fundus find. If I can have anybody either speak or, write in the text, and what they see on this fundus photo. Looks like pathologic myopia, great. Lacquer crack, that's perfect. So the arrow sign here is pointing towards a lacquer crack, and the arrow head is technically pointing to some area of, subretinal neovascularization. That's perfect. Myopic crescent, tessellated fundus. You can even see like these, maybe you can imagine the retina is a little bit thinner here, allowing visualization of the choroidal vessels. Perfect. So we'll go to the next slide. So pathologic myopia. There are lots of different posterior segment findings in pathologic myopia. And you guys got one of them right, lacquer crack. But there's lots of other ones that we can sort of talk about. So this is a little matching exercise. So can anybody tell me for lattice degeneration, which one of these phrases here is a definition for lattice? And we can just work our way down. So for number 1, lattice. Perfect. F, peripheral vitreoretinal degeneration, which predisposes patients to retinal tears. I'm sure all of us have seen lattice at one point or another. But yeah, it's always has these like sclerotic vessels, sort of, that those sclerotic vessels overlying that retinal degeneration kind of lent to its name of lattice. It forms like a lattice structure, this crosshatch structure that you sometimes see in like fences and things like that. Next, vitreous degeneration. Yep, that's correct. Eye, vitreous liquefaction, and vitreoretinal dehiscence. So myopes tend to have, vitreous degeneration earlier on. So macular schisis. Great. D, splitting of the retinal layers overlying the staphyloма. Yeah, so a macular schisis is splitting of the retinal layers, and the pathophys behind it is, one of the kind of theories is it may be associated with if you have posterior bowing of the posterior pole due to a staphyloma, you also have this like increasing axial length. So if you have a layer of the retina that can't stretch, what it'll end up doing is it's just stiffen basically, and as the rest of the eyeball grows, that allows the retina to actually lift off of the RPE. And so they think that it's because the ILM, the inner limiting membrane, is kind of stiff and not flexible, And so, that can cause these retinal layers to kind of separate out as the rest of the eyeball is grown. Next, lacquer crack, we've already talked about. Lacquer crack is G, right? A small area of rupture of Bruch's membrane. Again, another one of these things where the stiffer portion of, the stiffer tissues don't stretch, and because of that, you start having these cracks in Bruch's membrane. Exactly. And then 5 is fundus tessellation. This was one I just learned about. I always called it tessellated fundus, but I never knew what the actual definition was. And the definition of it is a repeating pattern of pigmentation. That's right, letter E. Between pigmentation, blood vessel, pigmentation, blood vessel. And so if I went back here on the slide, you kind of see like pigment, blood vessel, pigment, blood vessel, pigment. So that's, the real definition of fundus tessellation. And it's associated with choroidal thinning. So if you can imagine, if the choriocapillaris gets thinner, then you have the underlying Haller and Sattler layer vessels that can kind of show through. And then peripapillary intrachoroidal cavitation. So this was a new term for me. Just Dr. Prakash Baum. Looks like, yeah, correct. So it's H, which is a yellow-orange pocket around the optic nerve that's associated with the staphyloма. Initially, before like the swept source OCT and extended depth imaging, they used to believe that this was, like a retinal tear, or sorry, like an exudative retinal detachment around the nerve in patients with myopia. Oh, okay, so I see a little thing here from Dr. Tsedeke saying lacquer cracks versus angioid streaks. Angioid streaks are more emanating from the disc, that's right, and they tend to be straighter and are reddish in color. Yeah, so they tend to be a little bit, darker color, and they kind of, I don't want to use the word serpiginous, but they kind of have this like snake-like feature about them as they come out from the disc. Whereas lacquer cracks are just these little, yellowish kind of, looks like little cracks. If you think of like cracks in porcelain or something like that. That's sort of what lacquer cracks look like. Sometimes they're very difficult to see, but if you have all the other sort of posterior segment findings and you see a person with like subretinal hemorrhage, you're like, oh, this might be CNV, secondary lacquer crack. So, yes, so peripapillary intrachoroidal cavitations are, like we said, let's see here, in H, I believe, yeah. So yellow-orange pocket of pigment, pocket around the optic nerve associated with staphylomas. And actually it just is a space. It's not really, doesn't always have to be filled with fluid or anything like that. It's not a retinal detachment. It can actually, that cavitation can actually go into the choroid. It can have RPE overlying it. And I'll show you some photos too, to kind of see this in. Staphylomas, already mentioned. Number 7 would describe outpouching the wall of the globe. So it's a thinning of all the layers, including the sclera, and like a ballooning out of the wall of the globe. Number 8, tilted disc, not H. Perfect. C, it's an oval-shaped and obliquely rotated optic nerve head. Commonly, we'll have, situs inversus of the vessels, where the vessels, as they emanate from the optic nerve head, instead of going, just straight temporally, they can actually have a little circuitous route where they first go nasal before they go temporal. And then, sometimes you can have an enlarged blind spot or a nasal step associated with like a visual field defect associated with tilted discs. And it's very difficult sometimes to tell whether a patient's glaucoma if they have tilted disc syndrome as well. And then finally, dome-shaped macula. That's kind of a, what I think is sort of a newer finding, but I think it's actually been described back in like 2010 or something like that. So any idea what dome-shaped macula matches up to here? A, it's an elevation of the retina overlying an area of staphylomas. The key thing with dome-shaped macula is, kind of one feature of it is it's sort of very difficult to distinguish just from a normal fundus exam. And really once, OCT got better, that's when we started to notice this in patients. And the other thing is, in order to distinguish on OCT, a lot of times you need to have a vertical section through the fovea, and there you can actually see the actual dome. If you just do horizontal rasters through it, sometimes it's covered up basically because you can have such a large area that's associated with it that you won't be able to pick it up on just a horizontal scan. So it's good to have a vertical raster or even that star-shaped macular raster when you do OCT on these patients. And the pathophys, the thinking behind it is they think, it's usually over an area of staphyloma. And so if you have this ballooning out, outpouching of the globe, it's almost like a resistive effect, thickening of the choroid just in that region to kind of make up for the myopia that's being induced by the staphyloma. Not really sure exactly how that works. If anybody else knows from you out there. And so I'll show you some photos now of everything. Any idea what this might be? So from A through J is actually just a progression. And then eventually J is actually after they had fixed this with the vitrectomy and bubble or in gas. That's correct. Yeah. So Dr. Tsedeke says, for dome-shaped maculopathy, you want to make sure you follow them because you can have a CNV right at the, the apex of the dome. And so if you don't follow, then they'll come back to anyways for vision loss, and then you'll be scratching your head why. And I think somebody mentioned macular schisis, and that's perfect. So this is OCT of macular schisis. If you look closely, you can see there's still some vitreomacular traction here, which eventually released. You have all these like cystic cavities of the inner retinal layers, and these like vertical lines that are kind of holding everything together are thought to be Muller glial cell processes. They kind of act as a scaffolding for the retina. Eventually, the posterior hyaloid completely pulls away from the fovea, and then you actually have this foveal cyst that forms, and then subfoveal fluid, which gets worse with edema of the outer retinal layers. Gets a lot worse. Eventually, the whole macula is detached with subretinal fluid and a fair amount of edema of the outer retinal layers. And then what they ended up doing for this is vitrectomy, I think it was a gas, and I think eventually they were able to lay the retina back down flat. Another thing you can kind of notice is just how thin the choriocapillaris is here. And this is the sclera. And so you can easily get to the visualized orbital structure masses if you wanted to. It's just an OCT in these patients. Perfect BMT with macular schisis. That's right. All right. So the next picture. Any idea what this might be? A couple different diagnoses here, but the OCT really is showing you what I want you to say. Hey, first of all, I can see that it looks like a little bit of a tilted disc. Perfect. Yeah. Myopic crescent. That's good. Peripapillary intrachoroidal cavitation. That is the correct term right there. So, like I talked about before, that initially this was thought to be kind of if you didn't notice that this was a giant a very myopic fundus, you could sort of think of this as almost like an optic pit, but it is a little different in that unlike a pit, which is actually like sort of like I think they believe this is like CSF kind of leaking through the optic nerve head under the retina. This is just an outpouching of the globe just at the inferior optic nerve head. I think the last picture here kind of says it all, which corresponds to line F here. You can see that this cavitation actually has RVE overlying it. So this is why it's an intrachoroidal cavitation. And now we finally come to what we talked about a little bit earlier. So other than the tilted disc, the tessellated fundus, what else do you guys see in this photo? Perfect, an inferior staphyloma. That's exactly right. And I will say that this OCT scan is actually, this one is superior, that's inferior. So this is actually a vertical scan through the macula, which shows you what we talked about earlier. It's a dome-shaped maculopathy. So sometimes if you have this horizontal raster that's going right through here, you can actually miss this dome-shaped area. And right at the ridge of that dome, that's where you're seeing some choroidal neovascularization right there. And so like Dr. Tsedeke correctly mentioned earlier, you want to make sure that you're following these patients closely because they can have sudden CNV right in the center. The other thing is sort of a subtle sign here you can kind of see is, you mentioned correctly, an inferior staphyloma. You can see it's sort of, the fundus is actually sort of darker superiorly. There's this horizontal line between where the staphyloma starts and where, where the ridge of the dome is. And so that's kind of a little clue there. Tell you, that there may be dome-shaped maculopathy with an inferior staph form. All right, so here's another case. 20-year-old female with myopia presents with a 1-week history of flashing lights in both eyes. All right, now that we are all done with myopia, what do you guys think about this? Give me a little differential. 1 or 2, perfect. RRD, PVD, retinal break. Okay, now how about if I say this a little differently? A young myopic female with flashing lights in both eyes. Okay, we're still in the myopia route, but anything else in the differential? Somebody with flashing lights, aka photopsias in both eyes.
So bilateral, guys, bilateral, and
Bilateral.
and because we're switching more to case-based, right? This is a different chapter than myopia, if that helps you.
Okay. We're still on tears and lattice here. A young woman says, I see flashing lights in both eyes. And then I'll tell you, you do a fundus exam and, okay, migraine is a great thought. Yeah. Going along the same line, anything else? You do a fundus exam. You don't see any lattice or retinal tears or anything like that. Okay. You may even see no headaches associated with it. Let's say she had a viral prodrome. She said, oh, I had like a flu-like illness a week ago or something like that. All right, I'll give it away here. You see tiny little white dots everywhere in the macula. There we go. Okay, so we got one saying AMPI. What's another one? If she had no headaches and the dots were smaller, but yeah, along the right line. So AMPI and the whole white dot syndrome. White dot syndrome. So here we are, chapter 11, white dot syndromes. Perfect mutes. That's what I was going for. White dot syndromes are characterized by multiple discrete, well-circumscribed, yellow-white lesions at the level of the retina, outer retina RPE, or choriocapillaris. And there's a bunch of them, and they all sound the same. They're all very similar in terms of like their distribution, except for one. And so, anytime you see a table in the BCSC, best thing to do is to just stare at it for like 40 minutes and then pick out the things that make something stand out. Because that's what they do. So sorts of syndromes would include AMPI. That's how I say it. I don't know how you're supposed to say it because I wouldn't want to spell it out. But AMPI stands for acute posterior multifocal placoid pigment epitheliopathy. Okay, so it's acute. It's posterior, meaning usually affects the posterior multifocal, meaning it's all over, multiple areas of the retina. Placoid, so kind of these larger lesions, flat lesions, and it's a pigment epitheliopathy. Tends to be bilateral. One thing to remember is, which ones have kind of an equal, male/female predominance, whereas most of these actually have a female predominance. And they're all non-infectious forms of, inflammation of choroid retina. Instead of going through every single thing on this table, I'll just kind of put out some flat rules for you to remember, and then we'll quiz you on the rules, make sure life flies. So one of them, all of them are bilateral except for one. The one that's unilateral is mutes, right? So multiple evanescent white dot syndrome, mutes. And so you guys are right to think AMPI in that case presentation because AMPI is bilateral, whereas mutes is usually. But other things that it could be are bird shots or pigeoness, all those sorts of things, Azor even. But we'll get to all of this. So which affects older patients? So bird shots usually the only one that sort of affects patients past middle age, past like age 50. And then which ones affects choroidopathy and AMPI usually affect both males and females. And so those two you should kind of keep together because they kind of are very similar in their distribution. Serpiginous and AMPI. I mean, larger spots, Serpiginous and AMPI do tend to have larger spots, as well as Azor sometimes. And then similarly on FA characteristics, Serpiginous and AMPI also will have early blockage with late staining. Meaning early on, the lesion that you see is going to be dark, and then later on, the later phases of the angiogram, they're actually going to have, hyperfluorescence. And the key differentiating factor between serpiginous and AMPI on FA is that AMPI will have diffuse hyperfluorescence, like the whole lesion, whereas serpiginous usually tends to be just that leading edge. of the oh gosh, of the area of choroid that's involved. So it'd be like an outline hyperfluorescence in serpiginous, whereas AMP is like a diffuse hyperfluorescence. And then which ones are associated with vitritis, right? So multifocal choroiditis and birdshot are the only ones with vitritis out of these white dot syndromes. Now, if you're thinking about infectious, then that's a whole different route. But anytime you do see vitritis, you should also think about infectious causes, syphilis, Lyme, TB, sarcoid, all those things that you just rattle off anytime you think of uveitis. And then viral prodrome. So mutes and AMPI usually tend to have a viral prodrome associated with them. Patient will come in saying, I saw, I was feeling a little sick, or maybe I got the COVID vaccine or something like that. And so there have been cases associated with either getting the COVID vaccine or actually having COVID. And then finally, which ones actually have a bad prognosis out of all of these? Birdshot and serpiginous tend to be the two with sort of a worse prognosis. But then, AMP can be one of those things. And the reason is AMP can also cause inflammation in the brain. And so the only time you really have to do a workup for AMP is if the patient has any sort of neurologic deficits or complains of a headache. Then you should also do an MRI for that patient. All right, so now you have some baseline rules. And then we'll get to some of the pictures. So any guesses on what this lesion might be?
Okay, Karnam, just a question. Why MRI? What would the MRI show you?
It would show you inflammation in the brain, basically. Because patients with AMP can also tend to have like cerebral, I can't remember, I think it's a cerebral vasculitis. And so the MRI would help kind of differentiate that. That's right. And Dr. Tsedeke also mentions if it looks like multifocal choroiditis, but there's no overlying vitritis, you think of presumed ocular histoplasmosis. Now, this is kind of, I don't know where else in the world you find ocular histo, but I did my residency in Nebraska, which is right in this triangle part of the United States where histo is very prevalent. So I used to see it very commonly. And the mnemonic I had to kind of remember, is this multifocal, is this PIC, is this histo, is usually histo presents with a triad. And the triad is these like punched out lesions, small punched out lesions, usually has peripapillary atrophy. And also it's kind of like a histology slide in that it's very clear, meaning there's no vitreous haze or vitreous vitritis or anything like that. So the triad of ocular histo is punched out lesions, peripapillary atrophy, and like a histo slide, which is no vitritis. Going back to this slide, what do you guys think is going on here? Perfect. Somebody mentioned AMP, and I do agree with them. This can, sometimes you can look at this and say, well, is this kind of emanating from the disc? Maybe, but it's not really right around the disc. It looks like it's just a little off. But if it were emanating from the disc, one way to differentiate it from serpiginous, which tends to emanate from the disc, is that you look at the FA early blockage with late staining, but it's not an outline, it's the whole lesion that's stained. Infrared red-free photo shows loss of the RPE here, loss of the normal kind of hyper intense signal. And then you see this like outer retinal loss. So that's correct. Next we have another photo. So what do you guys think this might be? Perfect. And then serpiginous, that's right, serpiginous choroiditis or serpiginous-like associated. Yeah, perfect. You guys all got it. So similarly, kind of looks like AMP a little bit, but it's closer to the nerve, and it kind of looks like maybe it's emanating out from there. On FA, the later stages, you see that it does have an outline, not just high diffuse hyperfluorescence throughout the lesion. And once again, you have this like outer retinal loss. Oh, and then this is a little tougher. I'll tell you that the fovea is a little bit, has some like granularity to it, if that helps at all. But I think the key here, yeah, mutes is correct. Yeah, whoever said that, the OCT and the FA would be helpful for you here. Sometimes the white dots and mutes can be very faint, as this photo kind of shows, but the red-free image really kind of gives you that detail a little bit better. Shows you the sort of the loss of irregularity in the outer retina or the inner outer segment area. So and then eventually, if you look look at the OCT, you see these breaks in the ellipsoid zone as well. FA, the common characteristic is these multiple wreath-like hyperfluorescent areas. And a wreath is like it's like if you take multiple branches and throw them up to get a circle, it just looks like a little, basically circular pentagonal thing. And you'll see multiple of those lesions all over the posterior pole. That's mutes. So wreath-like hyperfluorescence. Next, what do I see? A lot of small white dots. Great, birdshot. And they're like, well, I remember at the beginning, I had so much trouble thinking like, well, how do I know it's birdshot and not multifocal or histo or blah, blah. Key is it doesn't look like a punched out lesion. It's sort of like creamy, a little bit, looks like it's like a deeper lesion. And so, yeah, this is birdshot chorioretinopathy associated with HLA-A29. Birdshot's the one that affects older people, like we talked about, a older age distribution, right? It's the only time where you get HLA testing. And then this is finally, multifocal chorioretinitis. Great. I think because sometimes you can see them like these areas of punched out lesions forming a line. And I guess the term for that line is called the Schlegel's line, the curvilineal pattern lesions nasally, right? And that's multifocal choroiditis. Then I have a couple more. This one we didn't really talk about much yet. I just sort of mentioned it offhand as something that also has like a big spots, large spots, acute zonal occult outer retinopathy, azor. And so one of the key things with azor is on fundus autofluorescent fluorescent images. You get this hypofluorescent area, the hyperfluorescent area with a normal autofluorescent area. I think they call it like a trizonal kind of trizonal area of fluorescence. It usually grows out from the optic nerve and causes an enlarged blind spot. And patients usually complain of either flashing lines or enlarged blind spot. And then these are just more images of azor as well. And on FA, you can see kind of similarly what we talked about, this trizonal sort of area. And then on ICG angiography, those areas, the lesion is actually hypocyanescent. Perfect, yeah, and it does cause an enlarged blind spot. So a visual field, free visual field can help you catch that a little. This is one that I probably would have had trouble seeing or catching if I saw this patient. They would come in similarly to all the other ones, complaining of flashing lights in their vision. So I'll give you a hint. C and D. So D is like a subtype of C, but A, B, and C kind of go together, and D is sort of different. So the fundus photo, maybe you can sort of make out, the same lesions in the red free image tend to look a little bit more reddish brown around the fovea. On the OCT, it's only affecting the outer retinal layers. I think is that serpiginous? It could be, yeah. Usually serpiginous, you could see it, just on this photo. So yeah, AIM. So that's getting closer. AIM stands for acute idiopathic maculopathy. What's another one that's sort of along those lines, but a little different? AIM is associated with Coxsackie virus, usually a viral prodrome. This person doesn't have any viral prodrome. Perfect. And acute macular neuroretinopathy has this outer retinal loss, basically. Also happens to be in myopic females as well. And then there's a subset of this, which we hear about more recently quite often, is PAM, paracentral acute middle maculopathy, which is similar to AMN, but just it happens to occur at the middle retinal layers. And so this area of retinal hyperintense signal tends to eventually lead to internuclear layer loss in the future. Okay, and then I'll give this one away. Kind of looks like CSR, but also has hemorrhages within it. And the patient had a viral prodrome. And somebody mentioned AIM earlier, acute idiopathic maculopathy. And so that's the, in your differential for CSR now. That's one thing that I added to my own differential once I, learned this stuff. Got it. So now back to this. Mudes is unilateral. Birdshot affects older patients. Serpiginous and AMP and AIM tend to, affect males and females equally. whereas larger spots, serpiginous ampi and azor, and then early blockage, late staining, serpiginous ampi again. Vitritis, usually multifocal choroiditis and birdshot have overlying vitritis. Viral prodrome, Mudes, ampi, and A. And less favorable prognosis for vision, serpiginous and birdshot. All right, so we're moving on. We got another case. We got a 30-year-old male that comes for a routine ophthalmic exam. Color vision is 3 out of 8 on Ishihara test. Otherwise, fundus exam's normal, and patient's not really noticing anything. How to differentiate between CSR and AIM? I think histories, sorry, just to answer one of the questions. History is very important. So that's what I would do from now on, basically. Ask anybody with CSR, do you have a recent viral illness? Usually, AIM is associated with Coxsackie virus, so they'll have the lesions from Coxsackie on the fingers, spots on the hands, and things like that. Other things you can do an FA because AIM will have fluid as well. Exactly, and there's no hemorrhage in CSR. Perfect. All right, so what do you guys think of this one? Person with poor color vision in both eyes, not really noticing it. Oopsies. Yeah, there you go. So we're moving on to a new chapter. Yeah, retinal dystrophy, congenital color vision. Great, that's perfect. That's what I wanted to hear. So, with color vision, the big thing to remember is with the names of it. Like, what is protoanomalous, proton, what the terms mean. Big pigments. There's a red, there's a green, there's the blue. So if you think of cables that you hook up to a video, that's how I remember it. There's a red, green, blue cable, right? And kind of in that order. If you want to be more scientific about it, you can think of the visual, the electromagnetic radiation spectrum. Red is the longest wavelength, blue is the shortest wavelength, green is in the middle. Any way you want to remember it. If you remember red, green, blue, and you'll know protoanomalous would be associated with red, deuteranomalous, green, tritoanomalous, blue. So 1, 2, 3, red, green, blue. However you want to remember it, try to get that remembered. Makes your life easier. Most of the times, it tends to be hereditary. Most of the time, it's a red-green color vision loss. And usually, it's that you're decreased sensitivity to green light, basically. It doesn't mean that you can't sense it at all. It's just reduced from normal individuals. That tends to be the most common. It's X-linked recessive, so usually it's males that kind of show this, and actually occurs in about 5% in the male population. Protoanomalous is decreased sensitivity to red light. That's about 1% of the population will have that, of males. And then tritoanomalous is more uncommon, and that's 0.0001% of males. So that's basically the most common types of color vision deficiencies you can have that are hereditary. And then one thing to remember, if the patient is coming in, they say, I have bad color vision, and you check and it's bad blue yellow vision, if you're seeing that actually most likely means this is acquired. Whereas if they're having more red green color vision loss, you can kind of throw it off to the side and say, yeah, this is probably just hereditary. Nevertheless, you should still get an ERG and do a little bit more workup if the patient says this is new, right? All right, so that's enough about color vision. Let's go on to an 8-year-old male that presents with blurry vision, difficulty seeing at night. Vision's about 20/40 in both eyes. That'd be 6/12, I guess, in both eyes. Fundus exam, OCT, autofluorescence, FA, everything's normal, basically, that you would do normally in your clinic. What other tests would you want to order this young boy with nyctalopia and blurry vision and a normal fundus? Perfect. ERG, yeah. So that would be the next step to order. So we'll talk about congenital forms of night blindness. There's congenital night blindness that is associated with the normal fundus, meaning nothing that you see. So this patient, probably has congenital stationary night blindness. Stationary means that it's non-progressive. And there's 3 different types of it. X-linked recessive type is the most common, but you can also inherit it as an autosomal recessive or an autosomal dominant fashion. If you have an abnormal fundus with nyctalopia and it was congenital, then your options are either fundus albipunctatus, and that's very impressive to see, and then Oguchi disease, which is a more subtle or kind of So ERGs, everybody hates ERGs because they're so difficult to read. But there's only a couple things you need to remember. And ERGs will be abnormal in many diseases, but only few diseases that it's like, pathognomonic. So a complete congenital stationary night blindness. I think the best thing to do first is to just look at a normal ERG. So this is a specific kind of protocol in ERG where they're looking at this patient that's with an on response and an off response. And basically they have a light, they're shining it for 200 milliseconds and they turn it off. And so when they shine the light, you get the normal A wave when the photoreceptors get activated. Then you have the B wave. Then you have this trough. And then eventually the light shuts off at 200 milliseconds. And then you have this depolarization, right? That's normal. In congenital stationary night blindness, you can still have a little bit of that A wave because in this disease, it's not the photoreceptors that are deficient. It's actually the transmission of the electrical signaling from the photoreceptor to the bipolar cells. So you would have this negative ERG basically telling you that, there's some things, stopping this transmission between the photoreceptors and the bipolar cells, which make up the normal B wave. And then actually in complete congenital stationary night blindness, the off response is still pretty active. Whereas in incomplete, you just have maybe a slightly smaller A wave, completely reduced B wave, and then not even the off response as well. And then this is like a more normal station on A wave, congenital stationary night blindness. This is sort of like a more normal ERG tracing you would see patients. So this is just a full field ERG, dark adapted 0.01 stimulus, pretty flat, dark adapted 10.0 stimulus. You can see the good A wave, and there's really no B wave here that you should normally see. The light adapted, the cone response is 30 hertz response. Okay, so any idea what this picture is? Keeping in mind we're still in congenital night blindness. Great, it's fundus albipunctatus. And I just want to let everyone know Dr. Narayani put in a little thing about the Pepsi mnemonic that we talked about. Ways to remember the causes of angioid streaks. That's right. We learned there's actually other ones on top of that too that we should all be familiar with. And then that's right. So fundus albipunctatus looks very similar to fundus, so retinitis punctata albicans, but usually that's like a progressive disease, so it's not stationary, it's not congenital either. Fundus albipunctatus tends to have this really striking appearance, little stellate dots all over the fundus, but usually avoiding the macula. And then you have this picture. One way to make this a little bit easier, it's along the same line of night blindness. It's congenital, but let's say the patient was of Japanese descent and this patient was dark adapted, right? Oguchi disease, yeah. And so Oguchi disease tends to have this striking phenomenon called the Mizuo-Nakamura phenomenon, where you have this like yellow sheen to the retina after a patient's retina has been dark adapted, and then you shine light on it for a brief period of time. It has to do something with byproducts of the depolarization of the photoreceptors and whatnot. But anyway, so that's called the Mizuo-Nakamura phenomenon, usually classic for Oguchi disease. Patient will also present similarly with night blindness, but has this fundus finding. All right, how about this one? A 30-year-old male comes with progressive blurry vision, peripheral vision loss, and then long-standing difficulty with night vision. And that's the fundus. Yeah, RP, got him. Yeah, so retinitis pigmentosa. I guess, I always would have called something like this RP as well. But I think, especially in the field of genetics and inherited retinal degenerations, it's moving pretty rapidly and the classification tends to change every few years. So the BCSC, this is their outline scheme for the chapter. So now they're moving to call them rod cone dystrophies. And I think the big deal here is, we're starting to realize we used to differentiate these patients based on the progression of the disease versus, how the phenotypic appearance of the disease, et cetera. But now we're going more and more towards a genotype of the patient, which gene is actually disrupted. So similarly, like what we used to call Stargardt's disease now is starting to be called ABCA4 related diseases. And so that kind of lets you realize, it makes the term a little broader, but then you're able to put in different phenotypes that kind of go along with that gene. And that's, the reason why is because now we're moving to an era of treatment for these conditions in our lifetime. And so with gene therapy, you want to be able to distinguish what gene is causing this phenotype to then move on to treatment. So rod cone dystrophies are, the new catch-all term for retinitis pigmentosa. And so because there's so many here and so many different kind of things you need to know about the different dystrophies, Pepsi is nice, right? So Dr. Tsedeke mentions, make sure with the Pepsi mnemonic, there's other things that can cause it as well. So NF, tuberous sclerosis, acromegaly. Yeah, so those are all things that I didn't even realize. So thank you for that. So yeah, so going back to these, I can't, I don't have the time to talk about all of these today, but I can talk about the things that, you're likely to be tested on if you're somebody studying for a test, or, the things that, more likely you should kind of keep on the tip of your, at the forefront of your brain when you see these kinds of things. Rod cone dystrophies, right? So we talked about retinitis pigmentosa. The classic kind of triad is bone spicules, waxy nerve head pallor, arterial or narrowing. You can have CME, epiretinal membranes, PSC cataracts, zonulopathy, optic dystrophy. One thing that you might want to know is like the causes of unilateral retinitis pigmentosa. Anytime you see unilateral, you should start thinking about things like infectious, inflammatory, things like that. Also trauma, siderosis. Duzen is one. Duzen is caused by, a worm that goes in the subretinal space and causes all this inflammation. Cancer-associated retinopathy and autoimmune retinopathy as well. So enhanced S-cone syndrome is another retinal degeneration, inherited retinal degeneration. Tends to have, similar peripheral vision loss, night blindness. They have these like nummular pigmented regions around the macula, outside the macula. And so, it doesn't necessarily look like RP, because these like circular point-like, pigmented areas. And if you do an ERG on them, you realize they have like enhanced cone kind of signaling. Whereas the rod signal is all gone. So this is one thing to, I remember always having to learn this over and over again. It's choroideremia, gyroid atrophy. Can look very similar, have these scalloped margins. Scalloped means these like, U-shaped sort of margins as their cobblestone degeneration, but just like larger plaques of those, and usually gets closer and closer from the periphery towards the posterior pole. Choroideremia tends to stay peripheral and doesn't usually affect the macula as much. And the borders of the choroideremia lesions tend to not be as like distinct, whereas gyroid atrophy has these like really impressive sort of distinct lesions with pigmentation at the posterior aspect. Why does it matter to remember them? Well, one you treat, one you can't treat. So gyroid atrophy can actually be treated with arginine restriction, B6 supplementation, whereas choroideremia is an X-linked recessive disease and usually tends to just progress, but at least it usually spares the macula. Whereas gyroid atrophy, if you don't treat it, can involve the macula, and patients can have severe vision loss. Once again, choroideremia is this one, gyroid atrophy is this one. Here's a fundus photos of what do you guys think this might be? Pisiform flex, lipofuscin buildup, dark choroid. I mentioned ABCA4 earlier. Yep, perfect Stargard's. So pisiform flex are these like little fish-shaped yellow lesions, tend to be lipofuscin, aggregation. What else is here? This looks like an egg yolk in the middle of the retina, in the middle of the macula. Best disease, you got it. Vitelliform dystrophy usually progresses into something that looks more like this. The test you want to order here, it's an electrophysiological test. EOG, perfect. Electrooculogram would give you a decreased Arden ratio. Basically, EOGs, you dark adapt the patient, have the patient move his eyes left and right, and then you measure the potentials, and then you light adapt them, have them move the left and right. And so you're measuring the light peak to the dark trough. It has to be greater than 2 if it's normal. If it's less than 2, then you're looking at best disease, basically.
Thank you so much, Dr. Karnam. That's awesome.
Thank you very much. I mean, I was really enjoying it, and hopefully others were learning a lot from it. So I just wanted to connect a little bit of some of the pathologies Anyone who wants to comment on this one? Very easy. Yes, excellent. CSR, and this one is smokestack appearance with this hyperfluorescence leakage, and there's leakage here and there's pooling here, so that's very nice. So CSR, sometimes in fundus autofluorescence you may find such type of hyperfluorescent areas, and you need to, especially in a patient who is really, kind of a workaholic, someone. I've seen patients who are software engineers who are always on their computers throughout the night trying to decode or code something, and most of them are the ones who have this one. And I've seen also patients who have thyroiditis, thyrotoxicosis, who came with such type of thing. So let's make sure that when we see CSR, we need to also counsel and at the same time look for other systemic problems. So that CSR is also part of a spectrum, which is linked to the pachychoroid spectrum. So when you have this extended depths, imaging, when you have this, when you can see actually more of the choroidal anastomosis and all these dilatations of choroid and so on, you need to think of pachychoroid spectrum. So this is something to think about. And when you have that spectrum, one thing you should always think of is this spectrum. So you have CSC or intraserous chorioretinopathy, and then you have this pigment epitheliopathy with only so this might progress to this one. Sometimes you have repeated CCR which resolves, and then it might turn to be like this. And then you may have some neovascularizations, which leads to some papilloma-like type of thing. So this papillomatous choroidal vasculopathy. And then there is this foveal depression, which is also associated with pachychoroid. And you have this very thick choroid. You can see this one. So this all features should be making you think of pachychoroid, and especially in a younger patient. I've seen there's a tendency to always think of age-related macular degeneration whenever you have CNV, but if you look closer, and if you have if you can see especially the choroid, then you should think of the pachychoroid spectrum. When there is chronic CSR, you need to think of that pigment epitheliopathy too. So especially there are risks for CSR, like I said, type A personality, when you have Cushing syndrome, hypertension, sleep apnea, or if the person is taking psychopharmacologic medications, pregnancy, all stressful conditions could lead to such problems. And then, of course, at first you need to be conservative, but then you can, if there's recurrence, if the fellow is affected, and there is an increase in visual need, then you might need to do PDT, or you might have to give medications like spironolactone, which is a mineral corticoid. But then, these things have been shown that they're not, having good evidence for improvement. But of course, when you have a neovascularization, you can give anti-VEGF, but not before a neovascularization. There is no evidence that anti-VEGFs could help in the resolution of subretinal fluid. So let's see some of the choroidal perfusion abnormalities, which will be the last topic. It could be arthritic or non-arthritic. So we could think of arthritis-related type of choroidal perfusion problems, or non-arthritic ones. If they are non-arthritic, think of hypertension, some emboli which may be associated with any cardiovascular problems. Think of TTP, think of HELP syndrome, especially in pregnancy. You might see such type of features, when you see this one, you can see there's some disruptions in the retina, but there's also thinning of the retina, and at the same time there is RP problems and choroidal problems. So there are signs. So when you see these small spots, So small spots, especially in the choroidal level, you need to think of all the risk factors, and we call them ethnic spots, and there is also there is infarction of arteriole that can lead to cygrist streaks, which are hyperpigmented flakes, and there is also this what you call Amaric triangle. So, or when you see these names, it's nice to be acquainted with them. Basically, they are kind of infarction signs of the choroid. So when you go deeper, when you go into the detail of the choriocapillaries, sometimes, it may not be the larger ones, but if it is posterior multifocal placoid pigment epithelopathy, the lesions will be like a choroidal lobule. These are like big lesions of choroidal lobule. So they increase in size in number with age. They look like cavitations within the choroid, and there will be RP atrophy, and especially it can be associated with RP atrophy, geographical atrophy. All these affect choriocapillaries. Pseudoxanthoma elasticum affects choriocapillaries. Diabetes mellitus associated with deafness can also affect choriocapillaries. And even if there is no RP atrophy, patients with choriocapillaries problem can be the disease can manifest with some kind of choriocapillaries affection or involvement. So when there is increased venous pressure, you could also have AV malformations, and this could be carotid cavernous fistula could also be manifested in such cases. So other choroidal problems, age-related choroidal atrophy. This is something which is also related to myopia, and you need to think of pseudodrusen or reticular drusen. So if anybody could tell us what's the difference between pseudodrusen and drusen, because this is very important. Where are pseudodrusens and where is drusen? Yes, pseudodrusen is above the RP. Exactly. That's the critical difference. So they can be one predicting signs for CNV, and so this is very important to notice. When you think of choroidal folds, you need to think of tumors. Of course, something pushes the choroid forward, but it could be CNV. We have said anything that buckles the cornea, the choroid could lead to those folds. But there is also hypotony maculopathy. The hypotony could be after glaucoma surgery or after trauma, whichever the case. Topiramate, which might be prescribed for increased ICP, can lead to cilicoidal effusions with no hypotony, and increased ICP could lead to folds which are circumferential to the disc, and we call them pattern lines. Of course, when you have choroidal hemangioma, you need to think of Sturge-Weber. So previously we've been talking about Weber-Mason, which are more retinal hemangiomas. But when you talk about choroidal hemangioma, it is more of Sturge-Weber, and sometimes it's called tomato ketchup. Typically, choroidal hemangiomas are difficult to circumscribe. You can see that it's a kind of orangey. I'm not sure if you can see it, but there is a demarcation here, but it's very subtle. So ultrasound B-scan is very important to see this one. And of course, what is typical of the A-scan or choroidal hemangiomas? Anybody could comment on that? H is high. The internal reflectivity will be high because you have intralesion. There is difference in the media, right? You have vessels which have lumens and then coming back and forth. So always the impedance would be dependent on the difference in the media, right? So you have different reflections within the lesion, as opposed to, example, melanoma, where you have like a double spike. Like the first one is there, and then you have another spike. But then within the two spikes, you have only small ones because it's kind of homogeneous. What does this look like? So you have folds here, right? You have folds here. You have kind of something which looks like CSR, but then you have this one. What is this? Thank you, Ashana, for the mnemonic. Yeah, does this look like a leopard skin? It looks like leopard skin, right? So it's a typical feature of what? Yeah, so it could be because of anything. I mean, anything in a sense. Uveal effusion syndrome is kind of, yes, it could be VKH. Yes, exactly. Thank you for that too. It is uveal effusion, but it's kind of a diagnosis of exclusion. So you need to think of. I've seen a lot of VKH associated with such type of feature. I've seen posterior scleritis associated with this. So you need to rule out all the cause of exudative detachment because before you think of just uveal effusion syndrome. But then once you rule out all these things, a patient who is young and hyperopic, and you could think uveal effusion syndrome. Of course, this is very something. Another one, which is giraffe skin. That one was leopard skin. Maybe the giraffe skin is a little bit localized, but you need to think of this also in case of cancers. Because this is like a paraneoplastic syndrome where you have melanocytic type of lesions around here with discoloration and also with some serious detachment of the retina. So think of cancers of when you have cancers of ovary, uterus, and then patient is being treated for that or not being treated for that, and then you see such type of feature, then think of this syndrome. Okay, what is the most common systemic condition associated with android streaks? This is something I didn't talk about, but maybe someone could say yes. Thank you. So then, sorry, the next one. A 5-year-old boy is found to have unilateral telangiectatic retinal basals with exudative retinal detachment. What is the histologic finding? Now, that's the question. I know you know the answer for the diagnosis is Coats disease, right? But then what is the typical histologic feature? Okay, so I'll help you here. So this is foamy histiocytes A, right? A. So it is foamy histiocytes and cholesterol crystals. This one is typical. The others could be there, like all the related to loss of capillary epicytes. Everything could be there, but these ones, like B, for example, can be for diabetic mellitus, right? This is not typical of this one. What is the mode of inheritance in von Hippel-Lindau? VHL, it's autosomal dominant. What is threshold? Threshold is a retinopathy. Threshold, yes, 5'8", yeah. So 5'8", 35-year-old wise, otherwise healthy mom presents with recent unilateral slightly blurred vision. There is serious subretinal fluid in the macula and choroid is thickened. The patient is minimally symptomatic. What's the most appropriate initial management? Yes, conservative.
What's the diagnosis, everyone?
Yes, yeah.
Perfect. Great.
Okay.
I think
Thank
they
you.
aced it, Dr. Tsedeke. That was fantastic. Really too good. I'm sure we can go on all night because it was too good. Well done. I see so many great interactive answers here today. So many tough questions, and you did such a good job. So well done. We have heard your calls and feedback. And we're so excited that you're all so excited by the lectures. Dr. Tsedeke, thank you so much for being here with us today. It has been such an honor.